Good afternoon. Welcome to our show. I'm your host, Melissa Bridgen. Today we are putting the COVID-19 pandemic in focus from the perspective of 5 Indigenous physicians from across the land. What are the worries, the challenges, the successes? What have we learned from previous pandemics that have affected our people? What's being done, what isn't being done but should be done? What's the role of ceremony and traditional medicine in all of this? It will be an incredible hour of discussion with your panel of Indigenous doctors. Unfortunately, though, today, for technical reasons, we can't take your phone calls as all of our lines are tied up with our panel who are joining us from all over the place. We still, of course, want to hear what you think. You can tweet us at APTN InFocus, and of course, if you're watching on APTN National News Facebook page, you can put your comments there. We will be back to normal, though, next week, taking your calls. So in most jurisdictions, Canada is reopening slowly, but we may not be flattening the curve just yet. A federal COVID briefing last week did say it is bending, though. Here's APTN's Todd Lamarand on where the virus is projected to be going.
Dr. Theresa Tam announced that things are on track when compared to the rates of infection in other countries.
Canada's total case counts continue to increase more slowly than most countries.
Tam showed this graph where the red curve is a worst-case scenario, while the green one is a best case if current health measures are continued.
That green range is exactly what we're aiming for, and we believe that we're staying within that zone.
But the briefing projected that even if we stay on the green curve, 376,000 to 3.75 million cases are expected, with approximately 4,000 to 44,000 deaths.
This is the scenario we are currently working towards, where each infected person only transmits to less than one other person. To stay on this green, best-case scenario curve, we must achieve and maintain a high degree of physical distancing while also maintaining a high rate of case detection and isolation and contact tracing and quarantine.
The briefing didn't mention whether these models extend to Indigenous people and communities, because there is no reliable data on infection rates. Indigenous Services critic Gary Vidal asked about that. Indigenous Services Minister Mark Miller answered that they only have on-reserve data, and provinces and territories aren't tracking ethnocultural testing for the virus.
Currently, given the urgency of the situation, that ethnocultural testing has not been done, but as a government, we're looking forward to moving forward and getting disaggregated data to ensure that we do have and have a specific response for Indigenous peoples or people that are, for that matter, more vulnerable to COVID-19.
Joining me now is our panel of Indigenous physicians. Dr. James Makokis, a family doctor who works in Kehewin Cree Nation, also in South Edmonton. Dr. Veronica McKinney, a family doctor and the Director of Northern Health Services in Saskatchewan. Dr. Lana Potts, she is the Medical Director of Elbow River Healing Lodge at Siksika Nation in Southern Alberta. Dr. Marlyn Cook, a family doctor from Manitoba working in Moose Factory. And Dr. Dan Cutfeet with the Namgis Health Centre in Alert Bay, British Columbia, which currently has a cluster of COVID-19. Thank you all for joining us. So I just want to throw this out to each of you. Take us back a couple months. What goes through your head as you learn about this pandemic is about to head our way and the impact that it could have in the communities that you serve?
For me, it's Dr. McKinney here, Veronica. To be honest, the pandemic has hit us. Our communities are in the northern part of Saskatchewan, particularly in the northwest. And we have some of the highest numbers right now, and I would say in our Indigenous communities, we are sort of the epicenter right now of the virus and of spread. And our numbers are still continuing to go high. We have, I think this morning I saw the numbers at 128 for our communities. So it is very, very scary for our communities, for sure. It's very frustrating on many levels, and I think we can get into that a little bit more as well. But it's also very challenging because it has so many new aspects to it. And I think what it really does at the end of the day is highlight the gaps that we see within our communities that we've seen for years, and the fact that we know that our communities are at a higher risk than the general population. So it's challenging. There's no other way to watch it. And at the same time, you know, we as doctors, we're Indigenous doctors, we're from the community, we're watching our people go through this and standing strong. But when you watch, you know, some of your elders pass away, which we've seen already in two of our elders, it's very disconcerting. It's very hard. So we're taught, in my case anyways, I feel that I'm sort of walking between two worlds, between the medical world and trying to be scientific and approach this in a manner that is logical and scientific, but in the same breath, you know, being part of a community and watching this unfold and recognizing the challenges that our communities face.
Is this kind of a worst case scenario, what you're living with right now? For our viewers, keep in mind La Loche is in the area that Dr. McKinney is talking about, very hardly hit by this virus. At the beginning of this, before it hit, was this what you're living right now? Is that kind of what your worst fear was at the time?
For me, yes. I was, you know, one can hope and dream that we would be bypassed somehow and that we would not have the virus hit our communities. But unfortunately, it just takes one and the spread goes. And so we are seeing it unfold. I keep hoping it will slow down, that we'll be able to stop it. So I still think there's hope. But it's pretty, you don't want to see anybody get this, and you don't want to see any deaths, and we're already there. So that's very challenging.
Do you have all of the equipment that you need to deal with this outbreak in La Loche?
Well, at this point, we have a lot on the ground, and there have been a lot of resources that have been deployed. And I think, again, it's difficult because sometimes you don't know what you need until you need it.
Right.
But I think for the moment, we are in fairly good stead. But it just depends how many people we have and how this changes. And the one thing about this virus, and in the middle of a situation such as we are in, is we know that it's almost a change minute by minute. You can be thinking one thing one day and it completely changes. And I guess that's the other piece that I would say is that the exhaustion that everybody is feeling around this is very, very challenging, for sure. Not only the workers, but I mean the community as well.
I'll go to Dr. Cutfeet now. You have a similar situation happening in Alert Bay. You have a cluster there. Tell us, share with us how the situation unfolded where you are and how you guys are dealing with it.
Yeah, COVID-19 is very real in Alert Bay. We have 30 positive cases to this date. 5 people were hospitalized, and we've had 1 death. You know, it's from our very first case. I think it was like the second week of April. It kind of exploded forward. You know, within a week we had 10 cases, and beyond that, you know, at 20, and then now we're all the way to 30. Really, it pushed our abilities, our resources, really very quickly, and we needed a lot of help right away. We did have offers provincially and sort of within our health. Mount Waddington health community, but really needed help in community and on the ground quite quickly, and we got that.
And this is the response that you got from, as you said, the province. Is this? Have you heard from your colleagues elsewhere? Is it widespread that there is this cooperation and the assistance, and people are getting what they need?
You know, I'm not hearing that necessarily widespread. I mean, there's a lot of places that, you know, they're fearful of having COVID experience in their communities, but they haven't yet had COVID in their communities. And so, you know, it isn't widespread, but definitely people are sort of bending over backwards to make sure that the resources are there for those communities. And, you know, people being quite frank and honest with the issues and you know, gaps in healthcare and problems with rural, remote communities, and trying to meet those needs before the pandemic even gets there. And so the conversations are being had, and really trying to meet those needs before the issues are pushed.
I'm going to throw this question out, and whoever wants to take it can take it. Are you concerned about the care that Indigenous people would receive? If say this virus took a toll like it does in Italy, like they did in Italy, where that would leave Indigenous people, whether you're sick with the virus, how you would be treated, or if you're sick with something else, and just hospitals and health centers are busy dealing with people who are sick from the virus. What goes through your mind?
Yeah, so I think, in Kehewin, one of the main factors that we made in deciding to close the community was the potential impact that racism can have on people when they go and seek out care. As Indigenous people, that's one of the things that we unfortunately face when we access the healthcare system, is not being treated in the same way that other people do, and not being able to access the same level of care that other people do. So having to take that in consideration as our emergency management pandemic committee, it's unfortunate that we still have to do that in this day, that racism is a factor in the quality of care that our people receive. But in forecasting into the future, if it was similar to Italy, we had to possibly consider, if it came down to our people having ventilators, would they actually receive ventilators? And our estimate was that they wouldn't. Really.
This is Veronica. I think we are already seeing some issues, and not even in terms of in sense of medical. So one example from our community is, of course, people still have medical conditions. We have a person that I know of that has to go out of the community to receive her chemotherapy treatment. And she booked a hotel, had booked it far in advance so that she could go down, rest overnight, and receive her treatment. When she arrived at the hotel, she was not allowed. They would not have her stay there. So here she is. She's driven quite a long distance, several hundred kilometers to come down for her treatment. Stressed about her cancer and trying to do what she can to be well. And she ended up having to drive another hour and a half to a family member where she could stay. And just the feeling of being turned away and because she comes from a community where COVID is located. And so it is very, very challenging on our people. Even things like you wouldn't think about, like groceries. So in one of our communities, one of the people who was positive worked at the grocery store, a grocery store that serves over 6 communities. Right. So all of a sudden, there's no food available for that community, or for all those communities. And it was the day that their checks came out. So people had bare cupboards with no place to go, and with the road shutdowns, they weren't, it was very difficult. So people would go to the nearest community, but because that was outside of the catchment area, we know that at least one person for sure got a fine of $2,800, I believe, for going to get groceries for himself and for his family and for some other members in his community. So, some of these challenges are not even medical. They are related to just basic daily needs that our communities are so reliant on things that they hinge on such small pieces that if that's gone, then all of a sudden it really does affect a lot of the people.
Dr. Potts, can you share with us how's the situation in Siksika Nation?
So thank you. It's really been, I think the challenges are similar on a lot of levels. We've been working in a lot of communities that do not have primary care, as primary care is not funded in First Nations communities. So a lot of we work with what we have, and what we're seeing is it's just blatant racism on a lot of levels. We have people turned away from emergency that are in crisis. I know of a close family member who was short of breath, and the local emergency turned him away. We're being told we'll see your patients. They're not allowing them in emergency. We have EMS sometimes not wanting to take people in. Some towns have actually made declarations to First Nations that we're not going to provide services for you, kind of keep your people in your own nation. We see this really as as a symptom of what's been going on long term. And I've said this before, that we were in crisis before this pandemic, and yet we're trying to now have another crisis added to us. And this really then paints a picture of what's wrong with our healthcare system. And I think Dr. Makokis had said something, and it was my fear, because on an online blog with physicians, it was like, well, we need to make a decision about who gets ventilators. It's like, they were deciding amongst themselves, and a lot of it was based on, whether they're doctors or teachers, or, they were more valuable to communities. And, and First Nations people were not really high on that list. And this was just something I read on a Facebook blog, but it concerned me as an Indigenous physician, as a physician who works primarily just with Indigenous people, about what are we going to do when we get sick. We, unfortunately, we do have outbreaks occurring, as people know, within some of the nations around Calgary, and there's been a response that was a reactive response, in my opinion, to dealing with the COVID outbreak there. I know the community didn't have a large vast of resources, and they did the best they could, but you see the federal government stepping in kind of a bit after, providing some support, but we don't see the support we need. I'm being told the funding has not shown up in the communities that was promised from the federal government. We're not getting the PPE, and these challenges that we're facing on trying to keep this at bay, especially around Siksika Nation, as we are one of the communities who sit around the epicenter in Alberta of the most cases. The city of Calgary has the most cases, and yet it's almost like it's lapping at our door, and we're trying to keep it away with all the prevention. And my worry is when it kind of comes over that wall, what's going to happen to and it's large populations, and as in the north and other communities, like you're looking at thousands of potential vulnerable people who don't have the resources such as hospital and transportation and access to medicines and even primary care in their communities to help deal with it. So we're facing a lot of challenges for sure.
Dr. Cook, can you share with us a little bit about what's going on in your region, what people might not know, what the situation is?
Hi. Well, I've been keeping in close touch with my home community, which is where I worked up until December 2019. And
that's Misipawistik Cree Nation.
Misipawistik Cree Nation. So I've been trying to help the people there as much as I can, because when all this happened, I was scheduled to start holidays March the 20th, and then they stopped all the plane traffic and started closing the borders just as I was starting my holiday. So it was, when I heard that the pandemic was coming, and we knew it was coming for a while, and I was fearful for the people in our communities, because I know that there are two health systems in Canada, one on reserve and one off reserve. I've been saying this for very many years. I'm the oldest one here. And, it's been that way, and it hasn't changed. We keep talking about racism and the fact that we do not have the same health system as other people have off reserve. So I was very fearful when I knew it was there, and I was going on holidays, so it was very difficult for me to be on holidays, and I had to go into isolation in my home.
Right.
And coming from Moose Factory, but participating in what they were doing with education and planning, and not so much I was participating in the planning, but attending the team meetings so I could make myself aware of what was happening up here for when I came back to work. And for Moose Factory, they've done a wonderful job. They closed off, like James said, we need to close off our areas. So they closed off the James Bay, western side of James Bay area, and there's very few flights, and the flights are met, and you have to go through a screening when you get on the plane. And they closed the train. They shut the train down for everything except for food and those kind of supplies to be brought in, but no people travel.
Right.
So we're fortunate in Moose Factory, that there is no cases as of now, because they shut it off pretty early, even before the winter road was supposed to be closed. they shut that road, which was good. And they've got, they've had the ability to prepare, and being a hospital, they have the ability to get more supplies, and they have set up a COVID ward, in case we do get hit with a large number of patients that are quite sick with the COVID. We still don't have all the equipment. There's still a need for concentrators. In my home community, Misipawistik, I've been working with a nurse practitioner who is shouldering this weight of the care of the people on her shoulders, because one of the things that happened is that the doctors were removed from the communities in the north. And, today is National Nurses Week, and I just want to acknowledge the nurses who are left in these nursing stations with very little equipment and very little education. Like when I see the education that I was able to participate in, on team meetings, and that, to be able to see what education was being done here compared to what's being done in my home community, and trying to, help them out as much as I could. But in my home community, we have 5 oxygen tanks, 5 big ones, 2 little ones, 6 regulators, and no concentrators. So, when a patient comes in, they need high levels of oxygen. So those 6, 7, the 5 big ones and the 2 little ones would be gone in no time.
Right.
Because we don't have those concentrators. And every meeting I've been at, that we've had these meetings with the minister, I've asked for those concentrators. And the other thing that concerns me is that, the squeaky wheel always gets all the oil, right? So the people who are able to strongly advocate and be very verbal are the ones that are getting the equipment and supplies. But it shouldn't be that way. That help should be going to all of the First Nations communities. So, like, all of us care for all our communities. Yeah. So to be able to get all the supplies in one area and not in other communities doesn't sit well with me.
Agreed.
And that, we need to be an advocate for all the communities, and we need this equipment for all our communities, the PPE, the concentrators, because most of the northern nursing stations have to rely on tanks. And if you don't have those concentrators, you're going to be out of oxygen in these communities, and that is concerning to me.
That's terrifying to think of. We have to take a quick break. We have lots still to get to with our panel of Indigenous physicians, including how COVID-19 is different than previous pandemics, and why did this one lead to a lockdown that the others didn't. Stay with us.
Join our conversation now. Call in toll-free at 1-877-647-2786. Like us on Facebook on our APTN News page. Follow or tweet us at APTN InFocus. And send your thoughts to infocus@aptn.ca.
Welcome back. Let's now go to some of the questions that our audience had for our doctors. I'm just going to throw them out, and whoever on our panel wants to grab it, please do so. The first question, can you catch COVID-19 again after you've recovered? Anybody want to grab that one?
So Dr. Cutfeet here. So I'm getting this, I'm hearing this a lot because of the COVID actually, being in our community of Alert Bay. And then, so we're having, almost pretty much everybody resolved probably by the weekend, and everyone kind of, wanting to get out and to resume some normalcy of their lives. And so people are asking, can you catch this again? And so, we're working closely with the medical health officer and public health, and really, we don't know. We suppose that you do have some level of immunity to COVID. We just don't know how long that lasts. Whether it's weeks, months, or a year. And so our belief right now is that you are, after having COVID, immune for a time. But again, we just don't know. I don't know if anybody else wants to add something.
Yeah, this is Veronica. My other understanding is that there are different antibodies that are formed, and in fact, that's part of a research project currently to find out, because there does seem to be different levels depending on what type of antibodies your body has formed. So what kind of immunity your body has formed or tried to form in response. So because of so much of these unknown, it's very difficult to say. And of course, we've all heard of cases where people have actually contracted the virus again, even after having it the first time. More so out of, I don't think there's any in Canada as of yet that we've heard, but from some of the other countries.
Another question was, when should we go to the health center if we think we have the virus?
So this is Dr. Potts. I can answer that. I think this gets confusing because we are told to stay home if you have a cough, sore throat, shortness of breath, which means you can't breathe, or a fever. And I think one of the best things to do is, of course, if you can't breathe, you're having chest pain, difficulty with, weakness and walking, of course, reach out to a 911. Within community, the goal within our community locally, what we do is we have two services. So we have a community, somebody who can come to your home to check on you. And for those who don't, reaching out to your local health authority, whether that's your public health or your health center. We ask you not to come to the health center, not that we don't want to see you. One is to protect you from traveling, for potentially spreading the virus, but also providing the best place to take care of you. For example, most on-reserve healthcare centers are just health clinics. They don't actually have capacity for emergency rooms. So if you're having difficulty breathing and other symptoms, you're maybe best in an urgent care. So the best thing to do is to contact and then provide a plan working with a healthcare provider. It's not a clear-cut answer, but that would save you from traveling, but also put you in the best facility possible.
And another question that somebody had, if somebody in your house gets COVID, will you automatically get it? That could be house or work. If you're near somebody who has it, will you automatically get it?
Dr. McKinney here. The answer is no, actually. We've had, of course, many people in our communities have many people in their households. Most people will have to self-isolate along with the person that they are living with. But it's interesting because not everybody gets the virus. So is that because of good sort of social distancing within the house, hand washing, wiping down? It's hard to say at this point. But it doesn't appear that everybody gets the virus necessarily.
Interesting. So those are our viewer questions. I want to move on with some of the other things that I wanted to ask you guys about. You have been meeting with Crown Indigenous Relations Minister Carolyn Bennett. If somebody could explain why that happened and how, and then what's ever come of those meetings.
Yeah, so I'll take that one. About 5 weeks ago now, Minister Bennett had reached out to me just to talk about some scenarios that are happening in the community. And what I realized is that there needs to be some direction and on-the-ground advice from Indigenous physicians who actually work in Indigenous communities. Because sometimes what we hear from government is that things are going really well in communities, and a lot of the concerns actually get filtered up through the bureaucracy, and the concerns are then watered down. And having a direct route to be able to discuss this with Minister Bennett and some of the other senior officials at Health Canada First Nations Inuit Health Branch is really helpful. And in fact, it's probably one of the first times that Indigenous physicians and family doctors have been engaged in helping to plan and give advice to the federal government, and it's very much needed.
Let's talk about the cash contribution. We have a clip here from Indigenous Services Minister Mark Miller. Let's take a listen.
Over $690 million in funding has been directly allocated by Indigenous Services towards the health response to COVID-19. This includes activities undertaken directly by the department, such as procurement of supplies and nursing services, as well as the preparedness measures being undertaken by communities.
Further to that, Miller claimed that his department responds to community requests for equipment and support within 24 hours and said that communities are coping excellently with this pandemic. I'm curious, just before we saw that clip, we were talking about the lack of things that are needed in medical health centers. Who wants to respond to those comments?
I quickly want to pick up what's something Dr. Cook brought up about equipment, because it's interesting that we talked about primary care at the beginning and how there is no, regular family doctors or nurse practitioners providing acute care and preventative care on most reserves in Canada. And one of the things that I asked about when I first started working in Kehewin about 3.5 years ago was the need for a crash card. So if we needed to resuscitate someone before the ambulance makes it to the health center, and what we were told by Health Canada is that we don't qualify because we're not a remote community. So now that we're in the pandemic, some of that money that you just talked about, we've been able to purchase equipment like virtual otoscopes, or we're working on getting a virtual stethoscope so that we can see our patients virtually. So the question is then, is there primary care? Are the reserves expected to deliver acute care and have that funded, or are they not? Is it only during a pandemic that we're expected to deliver acute care?
Yeah.
And if we have both health needs in the country, then why don't we have acute care, primary care on a regular basis? Why does it take a pandemic for some of these resources to be accessed by the community?
This is Veronica. I think the other thing that concerns me is, again, as James and everybody's mentioned, is the lack of primary care or the sort of parachuting in and out idea. But I also think, our communities are very well organized in many cases. So what their needs were they did lock down very early on, but there really wasn't any support for that. And then when in our province, in our case, when there was an actual announcement of lockdown, there was really very little support, and it was sort of a taking over. And I guess the other thing that's concerning is this idea of sovereignty and not really including the community leaders. We have a very strong group in our Northwest, the Northwest Incident Command Center, and they include our Métis communities, our chiefs, all of the people. And they have been very diligent and worked very hard to really protect their communities in the best way that they can, with no resources. And so it's a bit frustrating because I'm not sure where these resources are going and what that looks like. And as James was saying, I mean, there's so many pieces that, people would, I guess, not really think about in terms of what the needs are, but they are broad and varied. And, I think we do need to support our communities and our community people to do what they know to be the best for their communities.
Dr. Cook, I want to ask you, and this is something that we hear people on social media especially saying, how is this any different than SARS or H1N1? Why is this one shutting down our economies, our communities, our lives? What's the difference between H1N1, SARS, and COVID-19?
Well, I think that this one it's fairly new, and it's so quickly changing. Like it from my understanding, from what I'm reading in the medical journals, and it's changing constantly. So, like, for them to even get a vaccine, I think it's going to be very difficult because, well, it's the same as the H1N1, like, when they or the flu vaccine. Like, sometimes they don't get the right strain.
Yeah.
I think with this one, it's constantly changing, and it's so infective. I know H1N1 hit, some of the communities in Manitoba quite hard, but I think that this one, for whatever reason, is so much more infective.
Okay, well, I'm going to say we're going to take a break now. It's a little bit earlier, but I have a question that we didn't get to in the last segment that we'll get to in this next one. So everybody stay with us. We're going to take a break. When we come back, we're going to talk to our Indigenous physicians about traditional medicine and also ceremonies. Hot button issue. If you're following it along on social media, you must know this. Stay with us. We will discuss it when we get back. Welcome back. With Summerfest approaching, ceremonies and community events were set to take place in the coming months, but COVID-19 has postponed or cancelled many of them. Daryl Stranger tells us this impact will have on communities and the people who rely on them.
You probably won't be seeing ceremonies like this taking place anytime soon over the summer. COVID-19 continues to push back events around the world, and it's no different in First Nation communities. Sweat lodges are also affected by the pandemic, with some being completely shut down. Others will try open with social distancing measures. One of those reopening with restrictions is run by the Southeast Resource Development Council Corporation, which is made up of 8 First Nations in southeast Manitoba. The mental wellness facilitator says having sweat lodges open is just as important now than it has ever been.
Now, people are going to sweat lodge to help deal with day-to-day stresses. So it's still quite important, even though the purpose of it, the use of it has changed. It is still very important for a lot of people. At our sweat lodge, there are a number of people who are very regular attendees, and there are some who come periodically only when they feel a need to attend.
Young also added that sun dances, the most sacred ceremonies, will more than likely be postponed due to the size and community togetherness the ceremonies bring. Daryl Stranger, APTN National News, Winnipeg.
So ceremony, there are people saying that the ceremonies themselves actually protect from this virus. Others say that it's time to press pause on ceremonies. Others say it's find a new way to do ceremony. How has this affected you personally, and what are your thoughts on what you're seeing out there in the community or on the internet? I'll start with you, Dr. Cutfeet.
Yeah, so in terms of personally, I mean, Alert Bay, rather large community of 1,200 people. We have a big house, and traditions and culture is so important in this community. And really, for months now, we haven't been able to gather in the big house and to have ceremonies. And, we did have a death due to COVID, but also we've had 2 other people pass away during this time. And so really, as a community, not being able to come together and to grieve, but not only grieve, but to celebrate births and life, and to rejuvenate ourselves through the traditions and ceremonies. It does sort of add a level of of concern, of anxiety, adds to that grief and depression, because it is so important to a people, First Nations and Indigenous, going forward. So, yeah.
Dr. Makokis, we had a conversation about this topic as well, and this is something that has personally affected you. It's had to change the way that you do ceremony as well.
Yeah, so first of all, I want to recognize that ceremonies are really institutions of governance. There are health system, there are education system, and that our people, through federal legislation, have been adversely affected by having legislation imposed on us and having our ceremonies banned, which would effectively bans our governance and education and health systems. So our people are very attuned to things like this and are very sensitive to issues surrounding ceremony, first of all. The second thing is we have to understand, your previous question about how this COVID is different is essentially COVID-19 is like a virgin soil epidemic, and our people have experienced virgin soil epidemics in the past with smallpox and measles and tuberculosis, and we have the oral history of how those have devastated our communities. We also know how our people survived those previous episodes, and really it was for social distancing. And we also have to understand the experience of other nations. So, for example, the Lummi Nation in Washington, where COVID-19 has been transmitted in ceremony, and that was confirmed by one of our Indigenous physician colleagues there who works in the community, as well as if we look at the Navajo Nation, where people were continuing to gather, unfortunately, and that caused a huge outbreak on their nation, which has overcapacitated the health system and has unfortunately contributed to many deaths. So as physicians, it's important for us to be able to help our communities and leaders plan in culturally sensitive ways and to come up with alternatives that if people do want to go ahead with their commitments, that we're able to help them limit and reduce the amount of transmission and make it as safe as possible for people. So I think that's the difference when we look at some of the public health orders that have come out from Health Canada and across other jurisdictions, which effectively bans all ceremonies, that as Indigenous physicians who work in our own communities, we know what is possible and what might need to be possible and what can be adapted. And we can help provide that information to our elders and leaders and traditional medicine people to keep our people safe, because we do need those for our mental health, for our well-being, for all sorts of things. And so it is a very important issue to discuss. In fact, we're actually having a meeting with our elders tomorrow about planning for the summer. So it'll be interesting to see what happens from that. I know many other nations are in similar situations.
Yeah, absolutely. Dr. Potts, I wanted to ask you, that we do hear a lot of, or see necessarily here, but on social media, people talking about traditional medicines, what role traditional medicines have in fighting this virus, in preventing this virus. I'm sure have heard this too, what type of advice do you give to people when they bring up the use of traditional medicine in this?
So I had a lot of reflection on this question around personally and recognizing I live in two worlds. I live in two worlds as a Western doctor, but also as a very traditional Blackfoot person who was raised with my medicines and raised with my ceremony. And I think the challenge is recognizing that our ways of life are our medicine. Our way of life around ceremony and our medicine and it's not about plants, it's our connection with our land, it's our connection with our animals, it's our connection that becomes our medicine. And we can't just ask people, well, you have to just stop having your medicine, because one of the things when you look at it from an analytical perspective of the previous pandemics, such as TB and smallpox and the Spanish flu, was we didn't have our medicines. As our medicines and our ceremony was banned for a number of years, over 70 years in Canada, I look at the strength when you took that away. So we need to add that in a good way. We need to be able to recognize that and respect the role that this is how we live, that this is where we come from, this is who we are. That's when I say I am a Misipawistik person, it actually means I'm involved with that way of life. And to be able to have hard, fast rules, which the government often likes to do, is don't do this or don't do that. We need to take the approach as stated around to be fluid, to recognize that we give information, we learn information, and that role in helping us get better is a part of using our medicines, but it can be done in a good way and can be done in a safe way. And it may be recognizing how to do that from community to community and taking a generic response, which also can be done around, I always call it a pan-Indian. As we're not all the same. We respect the cultures and protocols across the nation in different places, that we need to recognize that around this approach too. So for me, it's something I counsel with I get asked this question a lot, and I really just take that it's going to be an adaptation. We need it. I will say that. It needs to be a part. Ceremony is something we do every day, but there may be concessions we make on rather having, a ceremony of 3,000, it may be having to be limited, and just to ensure that it's about the prayers and that personal relationship people have.
And I think the importance, I just want to add to that, our people have always adapted. If we look at what's happened in the past with our ceremonies being outlawed, I know that my grandfather talked about how they had to have sweat lodges and a teepee so the Indian agent wouldn't come by and see that they were practicing our spirituality, or that some of the sun dances in some parts of the prairies are actually shortened, or as in my nation, as our people were learning how to do our matutan, our sweat lodges again, that we actually went to go learn from other nations until we could remember how to do it ourselves. And so our cultures aren't static. We always respond to changes, and that doesn't make it bad or worse. It just makes us respond to the situation that's presented in front of us, so that we actually have elders and traditional medicine people into the future, and that we're able to continue practicing this on and pass that knowledge on to our future generations of children and grandchildren.
If I could add as well, I think the other thing that kind of bothers me is from a Western perspective, we talk about traditional medicines or practices as being almost like, in the Western world, we take pills, and so they sort of liken it to whatever our herbs or things are, or plants that we use. But I think, one of our colleagues, our Indigenous colleagues, who works over in Ontario, she talks about this as being like a birthing process right now, where we're coming through to a different way of working or being within the world. And I think for many of us, our ways of being are how we live our lives every single day. And when I think of it as being a birthing process, I really feel like, it's almost like you turn inward. And so we talk about praying every day and offering our prayers up. I have 2 young boys, so we've almost become more ceremonial on a daily basis, and really not taking that for granted, even though it's not as shared with with our larger community at this time. I think that what I am hearing from many different community people is that same idea that we are really practicing in that way and being able to partake in that way and feeling strength from those practices. I do counsel my patients or my community members as well to carry on making our teas or doing what you normally would be doing to help strengthen your body, strengthen yourself, to make sure that you are prepared in case it does hit you. So there's many different ways, and I think this idea of just sort of taking one thing or doing one thing, as James said, we've always been adaptable. We adapt to what we need to do depending on what the situation is.
I love that, and I hope that when we share these words of wisdom with our viewers online, that this gets spread far and wide, because I think that's a very valuable conversation that we just had that needs to be shared.
I do have to say, I was worried at the beginning of the pandemic that the gah or the skunk was going to become extinct because everybody was getting their skunk oil, and when you go to you do home visits, it smells like skunk oil. So it's very reassuring to see that our people are very strong in utilizing our medicines, and there's actually been a resurgence of it, which is exciting to see.
Well, I know here in Manitoba, the reaction was, everybody get your cedar tea. That's the direction it went here, which is, I mean, I guess better news than for the poor skunks out in Alberta. I'm curious though, what's do you feel that the worst of this is behind us, and if there's something to learn from this? I'll just leave that to throw it out there. Whoever, we've got a little bit of time.
Hi, it's Marlyn.
Hey,
I don't think the worst is behind us. I think with these pandemics, there's always a second wave. So I don't think we should get lackadaisy and, letting go of self-distancing and isolation.
Okay.
I think what I see, happening is that, as James and Lana spoke about, we have a resurgence and people are going to the back to the medicines. Like I left here in Moose Factory on March the 20th, but even the few weeks before that, every time I went in the bush, I would meet people that were picking medicines. They were getting the cedar. They were getting ready to, use that cedar for their tea and also for smudging their homes. And that is really good. And also I think that, I had a month to reflect and think and do ceremony. I smoked my pipe every day, and as I did the months, I got to the point where I was able to see that this virus is here to teach us, and just to, I see what's happening to Mother Earth with the decreased air travel and the decreased travel, period. There's a lot of positive things happening with the healing of Mother Earth. And I think we need to reflect on that this was sent for a reason for us to reflect, because if we continue going down that road that we were on before COVID, we are going to be in trouble as not just Indigenous people, but as humankind.
Yeah.
You know, so.
Yeah. Well, I appreciate those are awesome words to end on. We have run out of time here. I thank you all so much for taking time to join us, and I like that we can leave here saying that that's a lesson. So, Marlyn, thank you for sharing that with us. And we are so thankful to all you doctors for sharing your time and expertise. Grateful that we can share this with our audience. This episode will be available for download as a podcast on our website at aptnnews.ca/podcast. You can get it there. You can share it with your friends. It's also, of course, still lives on our Facebook Live. I'm Melissa Ridgen. Thank you so much for watching. Have a great afternoon, and we'll see you back here next week. Stay safe.